Hi, my name's Henry. I'm a second year radiology registrar currently working at the Queen Elizabeth Hospital, and this is the first in a series of lectures on musculoskeletal imaging. Today we're going to be talking about the basics of describing fractures and dislocations, and we'll go through a few examples as well. So the aim by the end of today is to be able to describe a fracture. Other specific things we'll be talking about are Salter-Harris classification and then particular types of paediatric fractures, briefly touching on what pathological and avulsion fractures are and discussing the complications of or potential fracture healing complications and talking about dislocations as well with specific focus on the shoulder, elbow, hip, knee and patella. Like I said, the hope today is to be able to describe a fracture to someone like you were describing it over the phone. Specific things we'll be talking about, or you need to talk about, are where or what bone it's located and where in that bone, what type of fracture it is. Is it a simple fracture? Is it got multiple parts? Is it breaching the skin? Is it complete or an incomplete fracture that gets more involved in pediatrics? And then to be able to describe how it's displaced or angulated or rotated. So when talking about the location of a fracture, when we're talking about the shaft of a fracture, or when we're talking about adults, we'll tend to divide long bones into a proximal, middle and distal third. In a pediatric population, what's really important is the relation of the fracture to the growth plate or the physis. So we talk about fractures being diaphyseal, meaning that they're in the shaft, metaphyseal, of the physis or of the growth plate, or in the epiphysis. There are many different fracture types. Transverse means, as it sounds, transversal through the bone. Oblique, again, obliquely through the bone. Spiral means it spirals around the shaft. Comminuted means that there's more than one fracture fragment. Segmental means the bone is broken in more than one place. Avulsed means that there's essentially a bit of bone that's been torn off by contraction of a muscle. So usually where ligaments insert, if there's been forcible contraction of a muscle, it can sometimes pull bits of bone off. Impacted means that there's the two fracture fragments have kind of been impacted. Torus, where there's it's sort of a buccal fracture, and greenstick is a particular type of pediatric fracture where you have break of one cortex and bend of the other cortex. So transverse at right angles to long bone. This is a transverse fracture of the mid-humeral shaft. Oblique to the axis of the long bone. Oblique fracture through the mid-shaft of the tibia. Spiral fracture. This is a spiral fracture of the distal tibia. So it's sort of hard to conceptualize in two dimensions, but it's kind of spiraling around the shaft of the bone. Comminuted or multi-part fracture. Segmental, meaning the bone is broken in more than one place. Avulsed fraction, as we talked about before, where a tendon or ligament tears away at the portion of the bone. Impacted, where there are fragments of bone that have been pushed into each other, so this is an impacted fracture of the distal radius. A buccal fracture, where we have bulging of the cortex, where we don't see a complete cortical break. And a greenstick fracture, where it's another incomplete fracture, where you have fracture of one cortex and bending of the other cortex. A compound fracture is a fracture, or an open fracture is a fracture that breaches skin. An interarticular fracture is a fracture that extends to the articular surface of the bone, so this is a distal radial fracture with intra-articular extension. We can also talk about the overlap or distraction of fracture fragments. Overlap meaning that there's some portion of the proximal and distal fragments that are overlapping, as we can see in the picture on the left, and distraction or separation of bony fragments. Displacement is shifting of the proximal and distal fracture fragments relative to each other, and it's usually described in terms of the distal fracture fragment relative to the proximal fracture fragment. So in this, we can see that the distal fracture fragment has been laterally displaced from the proximal fracture fragment, and on the right, posteriorly displaced against the proximal fracture fragment. It's important to remember anatomical position when we're talking about displacement, being that arms are by the sides with palms out. It gets a bit complicated in the arms, so sometimes people will describe them as volar or palmar displacement or dorsal displacement rather than anterior and posterior displacement. So here we can see that there is a fracture of the distal humerus, and this is a supracondylar fracture, so above the humeral condyles, and it has been dorsally displaced, or you could say posteriorly displaced as well. It's also angulated, but we'll get to that in a second. And this is a radial fracture that demonstrates lateral displacement or ulnar displacement, that being the distal fracture fragment has been displaced to the ulnar side. So we've got our thumb up here, so this is the radial side and this is the ulnar side. This is a humeral neck fracture. This is an AP projection, so there is medial displacement of the distal fracture fragment. And this is a lateral projection, so this is a sort of mid-radius fracture with dorsal displacement, this being the dorsal surface and the palmar surface or volar surface here. Similarly, we can describe angulation in much the same way, and it's again the direction of tilt of the distal fracture fragment relative to the proximal fracture fragment. So here we've got a femoral fracture on the right, and it is medially angulated. There are also old superior and inferior pubic ramus fractures. This is a mid-clavicular fracture with inferior angulation of the distal fracture fragment. And this is a distal radius fracture in a skeletally immature patient with dorsal angulation. So this fracture fragment is angulated towards the dorsum. You can also describe rotation. So there is a femoral neck fracture on the left, and we can see that we're seeing more of the lesser trochanter on the left. So it means that there's been external rotation, and clinically this is what it looks like. So in radiology, we attempt to follow sort of the rule of twos. Certainly very important is two views, meaning that we get two orthogonal projections for a bone. So like a frontal and a lateral. In joints like the hand, wrist, and ankle, and knee, we tend to get more than two views. We do an oblique or a mortise in the ankle, say. Two joints meaning that you'd image the joint above and below the bone that you're interested in. Two sides, we not routinely do bilateral imaging, but it can be helpful to have a side that's normal for comparison, particularly in things like acromioclavicular joints. And on two occasions, meaning that, say, for scaphoid fractures, a fracture might not be immediately apparent, and it sort of, if you immobilize it and give it 10 to 14 days, fracture lines can become more apparent. We'll go through that in a second. So two views, maybe not the best example, but you can be sort of forgiven for maybe brushing over this tibial fracture until you look at an alternative projection where it's clearly very displaced. Two joints, meaning that you're imaging where we've got a proximal ulnar fracture, and we're interested in looking at the joints above and below because we've got a disruption of the proximal radioulnar joint here that we may have missed if we had only imaged the bone. Two sides, here we can see that like I was talking with the acromioclavicular joints, we have a normal acromioclavicular joint on the left, and on the right we can see that the clavicle is, or the end of the clavicle is quite markedly displaced above the acromion, which would be consistent with a acromioclavicular joint injury. And on 2 occasions, like I was talking about with scaphoids, not so visible that there's a fracture in the initial imaging, but on follow-up imaging 2 weeks later, you can see there's more bone that's been resorbed along fracture lines, so it becomes more apparent. A pathological fracture is a type of fracture through an area of weakened bone. There are a few different etiologies. Things where there's reduced bone density, like osteopenia, osteoporosis, or osteomalacia. If you have an underlying bone lesion, be that a primary bone lesion or bone metastasis, or even a benign bone lesion. Genetic bone disorders like osteogenesis imperfecta or Paget's disease, and this is not exhaustive. So osteoporosis is defined by having a T-score less than -2.5 on DEXA, and it means that there's reduced bone density. There are both primary and secondary types of osteoporosis. On radiographic imaging, on CT and plain X-rays, you have loss of cortical and trabecular bone. You have compression fractures, so we've got wedging fractures of upper lumbar vertebrae here. We have sort of a more prominent vertical trabecular pattern rather than a horizontal trabecular pattern, and the bones just look less dense. Osteomalacia is bone softening due to insufficient mineralization secondary to any process that results in vitamin D deficiency or defects in phosphate metabolism. For vitamin, so either you can divide this up into poor intake, poor absorption, poor metabolism. So for vitamin D, something like cirrhosis or chronic kidney disease. Phosphate deficiency, again, inadequate intake or absorption. You have renal phosphate wasting, or things that decrease the deposition of calcium in bone. So we can see that there's a fracture of the proximal or of the right femoral neck just here, on a background of this sort of patchy mineralization of bone. Osteogenesis imperfecta is a congenital or genetic disorder of collagen type 1 production, involving bone and a few other things that we won't get into, but its hallmark features are osteoporosis with bones that are prone to fracture. Paget's disease is a relatively common metabolic bone disorder characterized by excessive or abnormal bone remodeling. Usually the characteristic radiographic features are expanded bones with coarse trabecular patterns, usually affects the pelvis, spine, skull, proximal long bones, and you can have various patterns of involvement like monostotic or polyostotic Paget's. Getting into bone lesions, so a simple or unicameral bone cyst. This is so we can see here we've got a well-defined lucent lesion in the upper humeral shaft with a narrow zone of transition, meaning that you can sort of get a marker and define or draw outside exactly where abnormal bone meets normal bone. It's centrally located. This is a skeletally immature individual in that their growth plates are still open. And this is associated with a fracture. You can see a fracture line here, and we've got this fallen fragment sign as well, another fracture line there. So simple bone cysts are common non-neoplastic lucent bone lesions, usually asymptomatic, usually seen in children in the first and second decades of life with a mean age of diagnosis of 9 years, common in the proximal humerus and proximal femur. Bone metastasis. Now there's a huge range of lesions that metastasize, or of malignancies that metastasize to bone. In men, it's most commonly prostate. In females, most commonly breast. Otherwise, you've got non-small cell lung cancer and renal cell carcinoma, which are probably the more common ones that metastasize to bone. Again, we've got a fracture through the proximal humerus here on this underlying loosened area of bone. We've got complete loss of cortex here. It's not as easy to get a marker and draw exactly where normal bone meets abnormal bone, which means there's a wide zone of transition. Things that sort of flag you to think this is a more aggressive lesion. So there are a huge range of primary bone tumours. Your differential really changes between pediatrics and adults, and depending on what location. This is an example of an osteosarcoma with a pathological fracture that's medially displaced and angulated. Unlike the bone cyst that we saw before, it's harder to draw a real line around this area of lucency in the distal femur, and you also have an aggressive type of periosteal reaction in that there's a Codman's triangle here, and a Codman's triangle here is a type of periosteal reaction where the periosteum doesn't have time to sort of ossify as it's being laid down, meaning that there's very sort of rapid growth. There's also this soft tissue component to it here as well. So this is an aggressive bone lesion, and like I said, osteosarcoma. So pediatric fractures that involve the growth plate are classified using the Salter-Harris classification, and it's important as it predicts prognosis for these types of fractures. A type 1 Salter-Harris fracture or a slipped Salter-Harris fracture is where the fracture line passes through the growth plate, doesn't involve the bone, and has a relatively good prognosis. Type 2, the fracture involves the growth plate and then up through the metaphysis, again has a good prognosis. Type 3 is a fracture that involves the growth plate and then involves the epiphysis, or goes down to involve the epiphysis, and is intra-articular, relatively poor prognosis. Type 4 involves both above, through, and below the growth plate, and type 5 is where it's a crush type injury where it damages the growth plate by direct compression. Type 5 has the worst prognosis. Type 3 and 4 have poor prognosis, and type 1 and 2 have relatively good prognosis. So like I said, type 1 Salter-Harris fracture is a fracture through the growth plate. So we've just got widening of the anterior growth plate here. Type 2 involves the metaphysis and the growth plate. Type 3 involves the growth plate and the epiphysis and is intra-articular. Type 4 involves above and below the growth plate, so the metaphysis, physis, and epiphysis, and again intra-articular. And type 5, it's a compression of the growth plate and causes damage to the growth plate through compression, and can lead to premature fusion. So other types of fractures specific to pediatric populations are bowing fractures. So they're incomplete fractures of long bones, often don't require intervention, and it's due to the degree of elasticity that pediatric bones can have. So we've got the ulna has a bowing fracture here, where there's an incomplete fracture where the ulna sort of changes direction. You've got a radius here. We've also got a green stick fracture here, which we'll go through in a second. So a torus or a buccal fracture is where there's buckling of the cortex but no sort of cortical break that we can see. And a green stick fracture is where you have a fracture of the cortex, say in the distal or in the radial diaphysis here, and angulation. So one cortex is broken, the other one's sort of bowed. So a stress fracture is a fracture that's caused by either overuse and repetitive application of force to a normal bone. It can also occur in normal use in a bone that's weakened, say an osteoporosis. and they're termed either fatigue or insufficiency fractures. Most commonly, they're in weight-bearing bones of the lower limb, like the femoral neck, anterior tibia, medial malleolus, talus, navicular, metatarsal necks of the second to fourth metatarsals. Plain radiographs have pretty poor sensitivity and can be normal, but as the fracture heals, it might show periosteal reaction, callus formation. MRI and bone scan can be more useful when an X-ray is normal. So here we can see that there's a healing fracture of the shaft of the fourth metatarsal. You can see the callus formation here. This is the navicular. We've got a hairline fracture through the navicular. Again, one of the bones that's common to have stress injury. And then there's a MRI that shows in the proximal tibia with lots of bone edema and a fracture line through the proximal tibia there. Bone scan can be useful when the plain radiographs are normal. So these plain radiographs, there's nothing really to see, but we can see that there's increased radiotracer uptake in the tibial diaphysis on the anterior tibia, which may be consistent with a stress fracture. So fracture healing can be broken up into three phases. There's an inflammatory phase, which is triggered by the broken periosteum and the hematoma itself, which helps signal an inflammatory reaction. The periosteum contains mesenchymal stem cells as well. In the reparative phase, the hematoma is replaced by granulation tissue, and an immature callus is formed. So progenitor cells in the granulation tissue differentiate into fibroblasts and chondroblasts. An extracellular matrix is formed of fibrous tissue and cartilage, and woven bone is deposited by osteoblasts, and cartilage forms around the fracture. And then later on, we have remodeling where woven bone is replaced by compact and cancellous bone to form cortex and medullary cavity. So there are particular complications of disturbed fracture healing. A delayed union is fracture healing that takes twice as long as it should for an expected location. Non-union is fracture healing that doesn't occur within 6 to 9 months, and these can also form pseudarthroses or pseudoarticulations. And malunion is a fracture that's healed but in a non-anatomical position. So on the left we can see this is a green stick fracture of the tibia. You can see it's a paediatric patient. You can start to see that there's cortex beginning to form, the callus that's beginning to form around the fracture site here. This is an example of non-union, so shaft of tibia and fibula fractures, and despite its attempts at plating, you can see screw channels there. There's been non-union of these fracture fragments, and in fact there's a pseudo-articulation that's performed, or pseudarthrosis, like a pseudo joint that's formed in the middle of these the tibia and fibula. And malunion is where, like we said, the fracture heals but in a non-anatomical position. So this is previously this person's fractured their fifth metacarpal, a typical boxer's fracture, and it's instead of being healed nice and straight, it's got a forward bend or a volar bend at the mid shaft there. So dislocations is a loss of anatomical congruence of a joint, and it can be described in terms of position of the distal bone relative to the proximal bone. Again, subluxation is similar to dislocation, or similar to a partial dislocation in that it's malpositioned but not completely dislocated. Some dislocations are associated with other fractures. For example, anterior shoulder dislocation can be associated with Hill-Sachs lesions or Bankart injuries as well. And because of important neurovascular structures that may be around these joints, prompt relocation is usually indicated. Sternoclavicular joint's not one that we usually see dislocated. So we take an angled view of the sternoclavicular joints, and if it's sort of displaced superiorly on that radiograph, it indicates an anterior dislocation, posterior dislocation, but you might need a CT to clarify, and I think most people would be getting a CT. A acromioclavicular joint, so the acromion is always displaced inferiorly with respect to the clavicle. There's a Rockwood classification that grades AC joint disruptions or AC joint injuries, and it's to do with the degree of elevation of the distal clavicle relative to the acromion and the degree of widening of the coricoclavicular distance. This can be helpful to get comparison views with the other side as well. This is a shoulder dislocation. It's anteriorly dislocated. We would usually get a scapular or a wide view or a lateral view to confirm that, but posterior dislocations tend to have more of a light bulb morphology to the humerus because it's rotated. Shoulder dislocations or anterior shoulder dislocations can be associated with Hill-Sachs and Bankart lesions. There's flattening of the humerus here, which might reflect a Hill-Sachs fracture as well. Elbow dislocation. There is a posterior elbow dislocation in that the radius and ulna are dislocated posteriorly to the humerus, and there are associated fracture fragments here, which are most likely from the distal humerus, but a post-reduction X-ray or CT would be able to confirm that. There are particular fracture dislocation patterns that happen in the forearm or of the radius and ulna, and I think we'll go through these specifically in upper limb talks. But this is an example of a Galeazzi fracture dislocation, where there's a fracture of the distal radius and disruption of the distal radio-ulnar joint. Lots of dislocations that can happen in the carpal bones. So here we have a lunate dislocation where the lunate has rotated volarly, as opposed to a perilunate dislocation. Again, we'll get through these in the upper limb talk as well. And there's also a ulnar styloid fracture. Finger dislocations. See a few of these. And here we've got a posterior dislocation or a dorsal dislocation of the proximal interphalangeal joint. Again, can be tricky to see on frontal projections, so always get orthogonal views. Hip dislocation requires pretty high force or high impact trauma for this to happen in a normal hip joint. This is a posterior dislocation of the femur. Again, you'd be getting lateral views to assess this as well. Again, posterior dislocation at the knee, and this is important because we have pretty important popliteal arteries running just behind the knee here. So there's potential for injury to the popliteal artery. So it needs to be reduced. This is a patella that's been dislocated laterally, and on the MRI after it's been relocated, there's all this white stuff here is edema in the bone. So we've got edema in the tibia and edema in the patella, where these two have been sort of bumped up against each other. And you can see that there's the medial patellar retinaculum that's completely disrupted as a result of the dislocation. Ankle dislocation. So here the ankle's been posteriorly dislocated, and it's in association with tibial fractures as well. This is a subtalar dislocation where the talus is normally located in the tibio-talar joint, but the calcaneus has been dislocated from the talus. and medial dislocation of the at the first interphalangeal joint. We'll talk about spine more in the dedicated spine talks, but here we've got a dislocation of the spine. So at C5-6, we have anterior dislocation or subluxation of C5 on C6, and we can see the facet joints, which normally sit nicely on top of each other. The C5 facets are perched on top of the C6 facets, and obviously you'd be concerned about potential cord injury, because your cord space goes from this to not very wide. There's dislocation or subluxation at L2-3 here, and you can describe it in terms of degrees of vertebral body widths, and then complete dislocation at L1 and L2, and obviously your spinal canal is going to be disrupted by this. Again, a fractured dislocation where T5 is there's a pathological fracture of T5. We've got all this abnormal signal in T5, and T4 is anteriorly dislocated compared to T5, and this is the spinal cord, which is being completely squished at this level. And that's the end of our quick run through basics of describing fractures. Like I said, we will get more into details of particular fracture types and fracture patterns in the relevant upper, lower, and spinal talks. But this was more meant as a guide to discuss how we talk about fractures and dislocations. And so when you're calling up orthopedics, or when you're on orthopedics and describing the fracture, you've got a sort of framework about how to describe those. Thanks.